Okay, I am going to go ahead and get started with these slides. Give me just 1 second to share my screen. So just as a reminder to everyone, we do offer CME and continuing education credit for these learning events. So in order to receive it, you would text 71194 to the number on the screen, and we'll make sure that we send these CME slides as well as the CME handout shortly after the meeting so that you have these instructions, and then complete the evaluation online by February 27th in order to receive credit. We're offering credit for medicine CME, nursing CE, pharmacy CE, and dietetic CPEU. And then finally, just as a disclosure, Dr. Ashman is, of course, co-director and has stocks in publicly traded companies, excluding diversified mutual funds. And with that, I will stop sharing. And today we are very lucky to have Dr. Mike Hung joining us, who is the nephrology program director for the Michigan Collaborative for Type 2 Diabetes and is an associate professor of medicine in the Division of Nephrology at the University of Michigan as well. Dr. Hung, with that, I will hand it over to you.
Thanks very much, Jackie. I'm going sharing my screen. Hopefully everybody can see that. It's a pleasure today to come talk to you guys about referral to specialists, and I'm going to try to give a nephrology perspective. These are my disclosures, nothing relevant. As Jackie mentioned already, I'm a program director for the nephrology aspect of MCT2D, and here are my other disclosures with grant funding and consulting work. Today, I'm going to go through the guidelines, what's out there, put out by different societies for nephrology referral, and go into those in detail. Talk specifically about when patients might require more urgent referral and how to go about doing that. And also to describe the initial workup in anticipation either of possible nephrology referral or even when you've made the decision for a nephrology referral, how might you start the workup to help make that sure that that referral is as efficient as possible. So starting with the guidelines, one of the guideline societies that's probably the most prevalent in nephrology is something called the Kidney Disease Improving Global Outcomes, or KDIGO. They put out a chronic kidney disease evaluation and management guideline in 2012. It's been updated partially since then, but this is still the main guideline, and this is still all relevant. So as you can see here, this is straight out of the guidelines, and I'm going to go over some of these in more detail, but you can see that the indications for referral for patients with CKD to a nephrologist include acute kidney injury or further abrupt sustained fall in the GFR, GFR less than 30. So this is one of the specific cutoffs, and I'll talk about that in more detail. A consistent finding of significant albuminuria, which they define as a urine albumin to creatinine ratio greater than 300. Progression of CKD, which I will also talk about in a little more detail and define. And then there's of course, other than CKD, there's several other related findings. So hematuria, specifically with red blood cell casts or significant blood cells per high power field, not otherwise explained. Hypertension refractory to treatment, potassium disorders, kidney stones, and then hereditary kidney diseases. So there's obviously a lot of different reasons that you would refer to a nephrologist, and I'll go over some of these in more detail as they pertain to chronic kidney disease. So first, that GFR criteria, GFR less than 30, which correlates with stage 4 or worse chronic kidney disease. I completely agree with this recommendation. There are some exceptions. For example, if your patient has limited life expectancy, highly comorbid or older age, or patient preference. Beyond those caveats, I do think that all patients with GFR less than 30 should undergo a nephrology evaluation, because at that stage, that's when the risk of developing kidney failure really goes up. In other words, your chances of living long enough once your GFR has gone down to below 30 to actually get to kidney failure, it becomes about a 50-50 chance as opposed to passing away before that time. And so obviously there's a major role for nephrology education and preparation for end-stage kidney disease. The other major caveat, though, is as I hope people don't take this as to wait until the GFR hits 30. And I think that's really important. That's not what this guideline is intended to say. And I think these days more than ever, there's a ton of great options out there, therapies to help arrest chronic kidney disease progression or even regress it a little bit in the earlier stages, which is, of course, a big part of what MCT2D is working to promote. So I would say that at the earlier stages, that lot of effective therapies such as ACEs and ARBs, SGLT2 inhibitors, MRAs, and emerging data about GLP-1s in kidney disease as well. So even earlier on, and I would say in my own practice, this is somewhat reflected, as I have definitely seen more and more earlier referrals over the years. And I think it's actually great. I think it's nice to be able to see a patient when their GFR is, say, 55, and talk to them about all of the different options, all the different things we can do to prevent them from going from here to stage 5, the kidney failure, as opposed to seeing them, for the first time in stage 4 and knowing that there's a high likelihood of progression and having to talk to them about dialysis on our first visit. The next criteria is consistent and significant albuminuria. Albuminuria is a really important finding in kidney disease. It's the earliest sign of kidney disease, and so it's part of the diagnosis of chronic kidney disease even before the GFR starts to fall. It is an important prognostic indicator. It's, of course, relevant for kidney disease progression, but it also increases the risk for acute kidney injury, all types of cardiovascular disease, and all-cause mortality. And lastly, it's a therapeutic target as well. So when we see significant albuminuria and we know patients are at higher risk, that is part of the criteria for the various therapies against diabetic kidney disease and for titration of those medicines as well. So putting those last two together, the GFR criteria and the albuminuria criteria, you can see how they apply based on the CKD heat map. So hopefully most of you are familiar with this heat map. Just to walk you through it, the rows are the different GFR levels that correspond to the classic stages of kidney disease. But the columns are the degree of albuminuria from normal, which is an albumin to creatinine ratio less than 30, to moderate 30 to 300, or severe greater than 300. And so as you can see here, just as we talked about in the guidelines, anybody in this A3 range with severe albuminuria, the recommendation is to refer even at a normal range, because this suggests a high risk person at risk for progression, and so earlier referral is appropriate. And anybody that has fallen to that GFR range of 30 or less, stage 4 or less, should also be referred. So that's these boxes here. The next criteria, progression of CKD. I think this makes perfect sense when you have somebody whose kidney function is getting worse despite our best efforts. It's worth taking a closer look and maybe getting nephrology involved. They define progression of CKD as a decline in GFR category. So for example, going from stage 3A to 3B, or certainly from 3B to stage 4 when you get that GFR of 30 cut off again. And that a fall of 25% or more is considered significant. Another way to look at it is rapid progression of CKD, which is defined as a fall in GFR of more than 5 mils per minute per year. And of course, I think we all see in clinical medicine that there can be a lot of fluctuations in GFR. So seeing some fluctuations, a lot of times the first thing I do is simply repeat labs, or I try to figure out what's going on. And so the more data points you have over time to see progression, the more accurate this is going to be, of course. Hematuria is one of the other indications, and I think it's important here to distinguish between urologic versus nephrologic causes. Urologic causes are going to be probably 90% of the reasons for hematuria in patients. So it's really a small percentage of patients that will have a significant nephrology cause. The clues for the nephrologic causes would be glomerular hematuria, which is you can determine by seeing dysmorphic red blood cells, which is this bottom right picture here, where you can see the red cell, but with blebs pushed off to the side, presumably because that red blood cell has been sheared through the glomerular basement membrane filtration barrier. Or if you see red blood cell casts, which is what this picture here demonstrates. I know some practices have urinalysis and have the ability to look under the microscope. Not all do. So I think what we all can look at are what I call the renal red flags for glomerular or nephrology related hematuria. And those findings would be proteinuria, because if you see blood and protein together, there's a higher likelihood that that's coming from the filtering barrier as opposed to anywhere else in the urinary tract. New or worsening hypertension, or new or worsening renal insufficiency, including acute kidney injury. When you see these red flags, you do want to think about whether this could be a serious condition such as an inflammatory kidney disease, in other words, an acute glomerulonephritis, which can be lead to significant permanent kidney damage as well as other associated organ damage. Sometimes glomerular hematuria can also be benign. There's a condition called thin basement membrane nephropathy that's hereditary, but not typically associated with significant kidney disease. And so I think keeping these red flags in mind in terms of when to refer to nephrology is key. And also in terms of urgency, because if you don't have any of these findings, even if it is glomerular hematuria, most of the time we're just taking a watchful waiting approach to that patient. Just to add a few thoughts to the guidelines, I kind of already emphasized this, but I believe there's no such thing as a too early referral. So I think if you're concerned about your patient, you're not quite sure what's going on, or you just want to double check, I think it helps to get a nephrologist on board to tag team a little bit, even if it's early on. And maybe if it's very early on, it will not result in a co-management situation. Maybe it'll just be a one-time evaluation. But once again, these days we have so many good tools to treat kidney disease in its early stages. I think that there really should not be such a thing as a too early referral. And also similarly, I'd say there should be a low threshold for referral if the etiology of the CKD is unclear, even if it's somewhat stable. One of the fun things, I think, in the last probably 5 to 7 years in my practice has been increasing the use of genetic testing. And that has become a lot more available for patients. And in the past, if we didn't know and there wasn't a strong indication for a biopsy, which is invasive, we might have just kind of took a watchful waiting approach. And I'm increasingly using genetic testing for some patients and have made more diagnoses in a number of cases that have helped, not in some cases with therapy, but always at least in terms of diagnosis and giving the patient some prognostic information. So I think if you're not sure what the etiology of the CKD is, there should be a low threshold there as well. Okay, in terms of urgent referrals, I think a lot of this is relatively straightforward. The two that are really come to mind is if there's a rapidly declining kidney function, either if it's acute kidney injury on chronic kidney disease, or you just think it's progressive chronic kidney disease, but it's moving fast. Obviously, getting some help there as they progressed through the stages of kidney disease is important for both counseling and to make sure we're not missing anything else. And then I kind of already alluded to this with the hematuria slide. When you suspect glomerulonephritis. So in other words, if there's blood and protein or things like that, that's our time is tissue version. So in other words, the sooner we can identify that and treat that, the better the outcomes. And I would recommend, I mean, you can always click on the urgent referral for to the providers, and hopefully that's enough. But if you're unsure, at least for Michigan Medicine, we always have the M line where you can call and reach a nephrologist to get an opinion about this. And also that nephrologist, whoever's on call, can facilitate getting somebody into clinic quicker as clinically indicated. Okay, so I'm going to go through the last part, just what you might consider doing as part of the initial workup to help us to help your patient. I'm going to go through each of these, confirming abnormal labs, looking at medication exposures, urinalysis, and ultrasound. So first of all, there can be such a things as false positive creatinine elevations, which we define as not being due to an actual decrease in GFR. Probably the most common is something that impairs tubular secretion of creatinine, because creatinine is normally cleared both by filtering and by secretion. And so if you block the secretion part, you're not actually affecting the GFR, but the labs will look like you are. Bactrim is a very common medicine and will block that tubular secretion. So if you happen to check while your patient's on Bactrim and you see a worsening creatinine, it's worth just waiting usually a few days until they clear the Bactrim and reassessing. Another area is increased creatinine generation, which comes from muscle. So things like rhabdomyolysis, even low grade, for example, patients on a statin with myositis. If they're nearly on a statin or they're complaining of muscle pain, you can check a CK level to see if that's elevated and could be contributing to the elevation in creatinine. Increased creatinine ingestion. Creatine supplements, I always try to remember to ask my patients about that. Some people who, for example, bodybuilders or like to exercise, build muscle, will take a variety of protein supplements, some of which can contain creatine, which is a precursor to creatinine and can elevate the lab values. And then sometimes lab assay interference with various medicines. I haven't seen this as much, but if you suspect this, you can always recheck after completing the course of antibiotics. There are some alternatives to serum creatinine. There's a cystatin C test, which does not rely on muscle mass. And so in some ways, this is thought to be more accurate than creatinine, especially in patients with extremes of muscle mass. This is a send-out lab in some places, but has been adopted in-house at other places. This is something you can order on your own, or again, it's one of the tests that we might order in nephrology if we suspect that maybe the creatinine is not fully reflecting the GFR. Can do timed urine collections for creatinine clearance. And then in terms of GFR measurement, this is available for clinical use, but it's a complicated test that takes several serial measurements over several hours. So it's almost like a research protocol. So it's not something we do very frequently, but that's something that we could order through nephrology, a nephrology referral. Urinalysis, I can't emphasize enough how important a urinalysis is for the initial evaluation of a patient, either with acute kidney injury or chronic kidney disease. So I always like to emphasize obtaining a urinalysis as the non-invasive kidney biopsy and as the first step. Having the urinalysis before a patient comes to see me in clinic is super helpful because it already points me in the right direction. We'll almost certainly get a urinalysis in the clinic itself, but because it gets sent down to the lab, I won't have the result back in time to be able to counsel the patient during the clinic. So we end up talking a lot about, hypotheticals. What if the urine shows this, then maybe we need to do this, that, or the other thing. So having a urinalysis ahead of time at the time of when the abnormal creatinine is extremely important. Some examples, if we see pyuria or positive leukocyte esterase, we of course think about a urinary tract infection, but there's other things to keep in mind, including allergic interstitial nephritis. So it might lead us to think about making some medicine changes, especially if urine culture is negative and it's not explained that way. It could be secondary to glomerulonephritis, especially if we see hematuria and proteinuria, which are the other key findings that we look at on the urinalysis in the evaluation of patient with CKD and AKI. And then a kidney ultrasound. I don't necessarily get this on everybody. Certainly, if there's any suggestion of urinary retention or obstruction, it's an important study. So older men in particular with who are at risk of prostatic hypertrophy, I will definitely get an ultrasound because they may not have symptoms and they could have some evidence of obstruction. It's also helpful to look at the size and morphology, such as echogenicity, or which reflects degree of scarring of the kidneys, to know if this is really more of an acute issue when it's a new finding, or if there's been some chronicity involved. And then, of course, every so often you'll pick up a condition like polycystic kidney disease on ultrasound that you didn't know about. In terms of the role of the nephrologist with the referral, I think there's a couple of different ways. It could be a one-time evaluation. I like to think sometimes I can be a good partner and a cheerleader. Sometimes it's kind of tongue-in-cheek, but sometimes you need an enforcer too. It sometimes helps for the nephrologist to talk to the patient about all the bad outcomes that could happen, like kidney failure and dialysis, if the proper steps aren't taken to manage the kidney disease or diabetes and blood pressure and things like that early on. So I'd love to help partner with primary care in that role as well. And I like to think of, sometimes I tell patients they have graduated from nephrology because they are on the right course of medicine. Sometimes they're already on the right course of medicine when they come see me, and I'm primarily just providing some reassurance. So it can be a one-time evaluation. And of course, we partner and co-manage in the long term, especially with more advanced CKD and complications, and of course, in patients that are progressing towards kidney failure. So I just wanted to summarize there. I think Jackie, we're going to move on to the next presentation, or do we want to do questions first?
Why don't we do questions now if there are any while this presentation is fresh in everyone's mind. So does anyone have questions for Dr. Hung around referral to nephrology? Okay, well, if no questions now, we can also circle back at the end. Thank you so much, Dr. Hung, for sharing that and walking through all of that with us. It was incredibly helpful. We're now going to transition to Dr. Jenny Iyengar's presentation. Dr. Iyengar is a physician who specializes in metabolism, endocrinology, and diabetes at Domino's Farms here in Ann Arbor. And we are very lucky and grateful to have her here to present on referral to endocrinologists. I'll hand it off to you, Dr. Iyengar.
Awesome. Can you hear me first off? And then can you see, let me get my screen pulled up here.
Yes, we can hear you and we can see your slides now.
Okay, let me just put it in presenter mode. So thank you for that kind introduction, and thank you for having me. As you mentioned, I see patients with diabetes almost exclusively. One of the perks of being at an academic center is you can really hone in on what you enjoy. And so I really enjoy working with patients with diabetes. And so I'm very happy to talk to you about this topic today. I have no disclosures. And so I wanted to start by saying that, like, when I was first told that this was going to be the topic, like when to refer to endocrinology, I see nothing but diabetes in my clinic, right? So on the one hand, I'm always happy to see any patient with diabetes that you want to refer my way, and any patient with type 2 diabetes specifically that you want to refer my way as well. So part of me was like, well, this is kind of a hard topic because I like to help and I, want to try to help if there's any struggles with any patients who have diabetes, I'm always happy to see people. But then in the back of my head, I also remember my medical director and the fact that we have probably a couple thousand referrals in queue for diabetes. And so even though I'm always happy to help and see any patient with type 2 diabetes, realistically, we know that endocrinology can't see the lion's share of type 2 diabetes. And so at other places, the ratios might be slightly different, but what I can tell you is that Michigan Medicine, there's about 14 to 15,000 patients who are managed here for type 2 diabetes, of which about 3,000 to 4,000 are, am I cutting out actually, Jackie?
No, you sound great.
Okay.
Yep, you sound good on our end, or at least for me. Well, a little bit just now. I might have spoke too soon, but it's been good.
Okay, it looked like I froze for a second there. So we have about 3,000 to 4,000 patients who are followed by MEND. So I always recognize that the lion's share of type 2 diabetes is managed in primary care. So we very much depend on our primary care group here to see the bulk of type 2 diabetes. And so then I was trying to narrow it down a little bit. And so I thought, well, like one way that we might narrow it down based on who's controlled and who's not controlled. So you could say someone who has uncontrolled type 2 diabetes with an A1C about 9 to 10, is kind of severely uncontrolled. So that might be the type of patient who we're more inclined to see. But even that's not exactly a great criteria, right? Because we know that there's some patients who might have a one-time high A1C, especially, this audience here who's, engaged in working with patients with type 2 diabetes. You might be able to get those patients started on medication, you might work on lifestyle efforts, and you might actually be able to get down that A1C very rapidly, particularly in patients that have like good beta cell reserve. And so you might find that, even patients with very high A1Cs, if you're able to get them down into goal fairly quickly by implementing, evidence-based medications, CGM therapy, diet changes, they might not actually need to be seen by us. So then who actually does need to be seen by endocrinology? And so I thought what I would do is I would tell you, give you a patient case today of someone who I wish would have been sent to us sooner as an example of who might benefit from seeing endocrinology. And so this referral began, as all good referrals do, right, of a patient of mine actually wanted to refer one of their relatives. So, I had seen a patient in clinic at the end of the visit, my hand's on the door, and they say, "Hey, doc, my aunt has type 2 diabetes and it's not well controlled. And can she get an appointment with you?" I technically am not taking new patients and haven't for a while, but I'm always, I want to help. So whenever someone says, "Hey, can someone see you?" I thought, sure, I'll try to get her in. And so I scheduled the patient with me. So this was actually, kind of initiated by this referral was initiated by the patient and the family. And so a little bit about this patient. She's a 70-year-old. She has a history of type 2 diabetes, hyperlipidemia, hypothyroidism, depression. She was diagnosed with type 2 diabetes about 5 to 6 years ago. And at the time, she had presented with altered mental status and a glucose over 1,200. I did not, when I was seeing her in clinic, we did not have any records on that hospitalization, so I'm not sure what workup was done at that time, but she was started on basal insulin after that hospitalization. And then she had never been tried on any other non-insulin drugs to her recollection, but her A1Cs had consistently been double digits, usually around the 11s since the initiation of insulin. And she was not monitoring her blood sugars at home. She had no family history of diabetes, and social history, just notable for she had a pretty extensive smoking history, but otherwise unremarkable. And she was depending quite a bit on family in terms of helping her with some of her activities of daily living, like driving and cooking. In terms of her medications, she actually is on very few medications, just on the Basaglar 22 units, and then she was taking some fluoxetine. And her exam was just notable for she was 49 kilos, so 108 pounds. Her BMI was under 19. She had no acanthosis, and her exam was otherwise unremarkable. And then we always do a point-of-care A1C for anyone who comes sees us in clinic. So her A1C was higher than what can be measured. So our point-of-care A1C machine can only go up to 14. And so she was just greater than 14, hard to know how much greater, but that's just the max we can get on that point of care. So then the question I would pose is like, when is type 2 diabetes not just type 2 diabetes? So I was seeing this patient with a medical student, and obviously this case raised a lot of red flags in my brain for like, what's going on here? So she was diagnosed with this at age 65, but in the setting of a low BMI, like her BMI was 18.9. She had presumably some autoimmune hypothyroidism. She hadn't had a thyroidectomy or anything, so I'm going to assume that that was an autoimmune-based component. And then she was very uncontrolled, despite being on, like, that's not a big dose of insulin, but keep in mind, per her weight, that's going to be a fairly significant amount of insulin. And so she was taking about 0.44 units per kilo. And she's never been tried on anything else, which is also interesting, because normally, like, when people are referred, they've been tried on other agents. So, it kind of got me thinking, and I was like telling the medical student, I'm like, we really need to test her and make sure that she doesn't have type 1 diabetes, right? And sure enough, then as I'm like digging through Care Everywhere, I found that actually she had been tested for type 1 diabetes, and her GAD was off the charts. It was beyond what could even be measured. So she had an extremely positive GAD antibody, yet the notes were still calling her type 2. And she was still being treated in a way like a type 2. She wasn't on non-insulin agents, but she wasn't being treated with bolus insulin. And so we know a patient like this isn't going to be able to get good control without bolus insulin, because we know that patients with type 1 diabetes need basal bolus. So knowing the classification of someone's diabetes can actually make a really big difference in terms of their management. And so just a quick reminder here for everyone, the differences between type 1 diabetes and type 2 diabetes. So we often think of, type 1 diabetes as being juvenile diabetes, and that is correct in a way. The average age that someone gets diagnosed with type 1 diabetes is around age 9, but it can occur at any age. I've had people in their 70s, 80s who have been diagnosed with type 1 diabetes. So don't let the age fool you into thinking that someone can't have type 1 just based off the age. Type 2, generally in adulthood, especially like after age 25, we're going to see a much stronger predominance of type 2 versus type 1. It is happening in younger adults. Still would be very exceedingly rare for it to occur pre-puberty, but we are seeing a little bit more type 2 in our younger generation. Weight can sometimes be a clue. So historically, folks with type 1 diabetes would have low body weight, right? Because insulin's anabolic. And so when people have an insulin deficiency, they tend to lose weight around the time of diagnosis. But again, that's not like a hard and fast rule. In terms of antibodies, the hallmark of type 1 diabetes is an autoimmune destruction of the pancreas. And so you're going to see positive antibodies, of which the GAD65 antibody is the most common, but you can also see zinc finger antibodies, you can see IA2, you can see ICA. Insulin antibodies are really only helpful in people who haven't been previously treated with insulin, but we sometimes do use those as well. Type 2 diabetes is actually a little more genetically inherited. So be careful again that just because type 1 doesn't necessarily run in the family, it doesn't mean you can't exclude it. And then the key there, though, is patients with type 1 diabetes are prone to ketosis. So again, it's very important in terms of your management of making sure you know what you're treating. And another way to think about this classification then would be to think about antibody positivity and to think about beta cell reserve. So there's actually a classification scheme that involves classifying diabetes not as sort of type 1 and type 2 doesn't encompass the whole spectrum of diabetes. So sometimes a more useful way to think about it is to think, does this patient have antibodies? And do I think that this patient has beta cell reserve? Are they able to generate insulin? And so the classic patient with type 1 diabetes is going to be someone who has antibodies and does not have good beta cell reserve, cannot generate their own insulin. Whereas a classic type 2 patient is going to be someone who does not have antibodies and does have an ability to generate their own insulin. So you can kind of see those two quadrants of sort of our classic type 1 as well as our classic type 2. But patients can fall outside of those classic sort of groupings. And so, for instance, someone might be antibody positive and still have significant beta cell production. So that upper left corner, right? And a few examples of what might fall into that might be someone with very early onset type 1, where they still have a little bit of residual beta cell function. Another example that might be LADA, so latent autoimmune diabetes of adulthood. Those patients can sometimes have antibodies, but can still have beta cell reserve, and at which point you would still treat them similar to a type 2 patient, right? And then on the other end of the spectrum, you can have some patients who are antibody negative, but don't have a lot of C-peptide, don't have a lot of their own insulin. So those patients you're going to probably treat more closely to a type 1. An example of that might be someone with like checkpoint inhibitor induced diabetes. So those patients who have diabetes as a result of being put on, checkpoint inhibitors for a cancer diagnosis, they won't have the classic GAD antibodies, but oftentimes they can still have really like markedly low ability to generate their own insulin. So in terms of when you should refer to endocrinology, I pulled this essentially straight from our referral guidelines. But anytime you suspect someone has a specialty form of diabetes, got a little ahead of myself there. Anytime you suspect someone has a specialty form of diabetes, that might be a time that you think about referring. So if you have suspicion that someone actually has type 1, maybe you're concerned they have LADA, they have pancreatitis-related diabetes, or if they have diabetes related to pancreatic cancer, often patients who are going to get their pancreas removed because of a cancer diagnosis, they'll actually even see us before that just to kind of prep them into that and get them ready for insulin. Cystic fibrosis related diabetes, I find that the cystic fibrosis, like the pulmonologists do a very good job of testing people for diabetes and making those correct referrals. So you may not see that one an awful lot, but that is actually something that we commonly see here. It just usually comes from the pulmonary doctors. Atypical diabetes, MODIs, which is it's an autosomal dominant inherited form of diabetes, as well as gestational diabetes, diabetes in pregnancy, and I put that checkpoint inhibitor diabetes at the end. And of course, you might be saying, well, if I knew that they had one of those forms of diabetes, right, then I'd refer. But like, how do I know? Like, when should I suspect this? So think about anyone who has a history of pancreatitis, anyone with known pancreatic cancer, hemochromatosis, alcoholism, autoimmune disease. Again, like people with type 1 diabetes and a parent are much more, about a 6% risk of having type 1 diabetes in the child. But a lot of times autoimmune diseases travel in packs. And so sometimes it's not necessarily type 1 that runs in the family, but other forms of autoimmune disease that might run in the family. And then anyone who is diagnosed young, anyone diagnosed under age 25, it should be somewhere on your radar. And again, these are things that actually in our referral forms, like if you check any of these categories, it will actually it moves the patient more towards the front of the line to be seen, just so that we can make sure that we're not missing someone who really has a different form of diabetes, and that you might need to take that into account in terms of your treatment regimen. So just to kind of hit this point home, I just wanted to share another case with you. This was a patient who had type 2 diabetes, but just thinking about knowing what you're treating in terms of developing your treatment plan. And so this was a patient who I saw, I had followed with her for a couple of years. She had type 2 diabetes. It was diagnosed in 2010. She was initially treated with metformin. And then in 2016, she was hospitalized for pancreatitis with pancreatic necrosis. And her hospitalization was complicated by DKA in the setting of ongoing alcohol use. And her A1C during that admission was 11%, and she was discharged on basal bolus insulin. She was never super consistent about taking it. She kind of was a little bit hot and cold. She'd take it for a while and then would stop taking it. So she had a hospitalization for DKA then in 2018, and her A1C at the time had been 14.6, and pretty significant DKA, right? Her pH was very low, less than 6.8, and she had a big anion gap and a high glucose of 542. She then had another DKA hospitalization in 2020 after not taking her medication for several months. So she probably has some ability to generate insulin, right? She cannot take her insulin for a few months and doesn't go into DKA right away, the way someone with type 1 would probably go into DKA pretty quickly if they weren't taking their insulin, but not enough. She's not generating enough insulin to keep her out of trouble, right? So she's still, she's had at least 3 episodes of DKA. And so this is what I had put in my note when I was seeing her around this time. I said she has type 2 diabetes, right? She doesn't have type 1 because it's not antibody related. But I said that she's ketosis prone with recurrent DKA, possible pancreatitis component, and insulin is an essential part of her regimen in order to avoid DKA. And I commented that I would avoid SGLT2s in this patient given that she's ketosis prone, and I would also avoid GLP-1s given her history of pancreatitis. And this is actually like verbatim from my note, and even the underlying is all sort of verbatim. But then we ran into an issue in 2022. She had established care with someone new. Her A1C at the time was 14. She hadn't been taking her insulin consistently, and she was having diarrhea with metformin. And so the decision was, because she wasn't taking her insulin consistently, to just stop it. She's like not really taking it all that often anyways. And because she was having diarrhea with metformin, the decision was made to stop the metformin. So she was advised to just stop everything and start Trulicity. But then again, keeping in mind, we know she's ketosis prone. We know that she is somewhat dependent on insulin in order to stay out of ketosis. And so about 2 weeks after she was advised to switch over to the GLP-1, unfortunately, she ended up in the ER, and she ended up with another episode of DKA. She was seen by my colleagues on the consult service, and she was restarted on basal bolus insulin. So this is, I think, a good example of this patient has type 2 diabetes, but she has a more complicated picture because of her history of ketosis and because of her, pancreatitis history and history of pancreatic necrosis. And so knowing what you're treating can be really helpful in terms of thinking about which agents are appropriate, and thinking about who's going to need insulin in order to stay out of ketosis. So kind of to summarize the first part of this, when should you refer to us? Yeah, you can refer anyone with type 2 diabetes who's uncontrolled, but especially patients who might more benefit from seeing us would be patients if there's clarity needed regarding the type of diabetes, or if there's clarity needed regarding appropriate agents, like if they need insulin, if they don't need insulin, if some of our non-insulin drugs are appropriate for them. Or if they're just not responding to the treatment plan. So someone who has a high A1C and you get them going on something and they respond, that's great. But if someone's not responding to the plan of care, sometimes we're there to help and see if we can kind of maybe talk to the patient, approach it in a way maybe that we can, help the patient out in terms of getting their A1C down. So I wanted to then talk about some other times that you might want to refer. So I find that a lot of folks in primary care are really comfortable with insulin starts, but every once in a while that there's someone who just isn't necessarily comfortable knowing how to start insulin. So if someone needs an insulin start, that could be someone that you refer to us, depending on your comfort level. If you are feeling comfortable starting insulin on your own, rock on, that's fantastic. But if you need us to help someone who you think might be appropriate for insulin, let's say they're already on 3 non-insulin agents and their A1C is still double digits, right? That might be someone appropriate to send to us, because we're always happy to get patients started on insulin. That's something we're very comfortable with. And we have really great diabetes educators and people who can work with folks on insulin starts. Another time that you might consider referring might be someone with type 2 diabetes on basal bolus who needs regular insulin titration. So, this is something that we do real commonly. I would say this is probably the lion's share of the type 2 diabetes patients that I do see, are people who have are on basal bolus insulin, and they just need someone to see them every 3 or 4 months and make continual titrations. So we're always happy to do that. Now, I want to put an asterisk on this one because another time that we often see patients is type 2 patients who are on CGM and they need regular review of their CGM and titrations of their medications. That's something that, again, we do very commonly. We download CGMs in all of our patients who are on CGMs. Because this is an MCT2D crowd, I know that you guys are all very CGM savvy, and probably a lot of you are downloading your own CGMs in your practice. But I know that not every practice has that capability. And so I think CGMs are great tools, but they're especially great tools if you're actually downloading the data and using it. And so if you need someone to regularly look at someone's CGM in order to make titrations, we're always happy to do that. And then finally, in terms of sometimes referral, we often get referrals of this patient needs an insulin pump. And I will say the reason why I grouped that in the sometimes category is because a lot of times, whether someone needs an insulin pump or not really has nothing to do with their A1C. So we get a lot of referrals of this patient's A1C is 14, therefore they must need an insulin pump. And really an insulin pump has nothing to do with sort of how high their blood sugars are. Insulin pump is a different way of giving insulin. And so, sometimes what happens is patients will be referred because the impression is that they might need an insulin pump to manage their diabetes. And really, sometimes I even go the opposite direction. Sometimes I might put them on a split mixed insulin or simplify their regimen, and that might actually allow them to, take their insulin more consistently. So it isn't always making things more complicated with an insulin pump, which insulin pumps have some great features these days. They can do some great things. But they also come with a lot of like troubleshooting, a lot of alarms and alerts. So it is and there's a learning curve for them, for patients. So it's not always the be all end all solution. And so I often will have, discussions, like realistic discussions with the patient about whether I think an insulin pump will help them or not help them. And there is always a caveat that, Medicare only covers insulin pumps for patients with type 1 diabetes. So particularly since we're talking type 2 diabetes here with MCT2D, just be aware that not all insurers are going to cover pumps for patients with type 2. Now, if you already have a patient who's already on an insulin pump, then yes, like we love to see patients on insulin pumps. And again, there's so much good data that can be downloaded off of those pumps. So if you have a patient who has an insulin pump and you are not able to download that insulin pump in your practice, then definitely, yes, we want to see that patient so we can download their pump and just make sure that the pump is working for them and they're getting the most out of that device. So then that brings me to, when should you not refer to endocrinology? I was asked to bring this topic up. So if you just have a patient and you know that they would benefit from CGM, but you're having trouble ordering that, and again, that's something that I know MCT2D has been working on, and I assume most of the people on this call are probably very comfortable ordering a CGM. But if you just need help getting your patient a CGM, that can actually just go through diabetes education. I know at least at Michigan Medicine, our diabetes educators can help put together pump orders to durable medical companies. They can help patients choose which CGM would be most effective for them and talk about different features of the different CGMs, and they can help get those orders off. And then they also can train patients. So if patients need to start a CGM and they need, maybe their patient's not super tech savvy, they might benefit from having someone help them like set up the app on their phone or things like that. Our diabetes education is always happy to help there. Another reason not to refer would be someone with diabetic neuropathy. I do get a few of these referrals. And I'll say if the concern is about atypical neuropathy, like it's sort of, they have some symptoms that may fall under diabetic neuropathy, but you're kind of wondering if it's not really diabetic neuropathy, if something else is going on, I would usually refer that to neuro. They're going to do a really detailed neuro exam and be able to tell you, whether something's neuropathy related. In terms of thinking about like medication options for neuropathy, I think a lot of us are familiar with these, but my usual go-tos are going to be gabapentin and then Lyrica, pregabalin, and then duloxetine. So those are the three that I'm going to use, by far the most common. And then I also use topicals, capsaicin, lidocaine patch, menthol. And so, those are going to be our mainstays. And then the final one would be like diabetic shoes or diabetic foot wounds. Diabetic shoes, orthotics and prosthetics can help get people fitted for the correct shoes. And as far as diabetic wound care, we have an excellent podiatry division. They do just wonderful things for people with diabetic foot wounds. They can do all sorts of wound care. They also do contact casting and a lot of really involved things to try to limb salvage. And so I would strongly encourage you to use podiatry. They're a great resource, particularly here, because they can see folks either in the endocrine clinic here. So they are part of our division. So they see patients within our clinic, or they also have the wound care center that they see folks at. But where this comes up, and I get a lot of referrals to see me for diabetic shoes, but what it actually comes down to is the documentation of the foot exam. So I just thought I'd mention that because if you just document the foot exam, O&P will actually take care of ordering, helping you order the shoes or pick out the right shoe gear. But they do need documentation from the person who's managing the diabetes. And so a lot of patients who are referred to me specifically for diabetic shoes, it's simply a matter of getting the right documentation down so that they meet criteria. So just a reminder, there's for Medicare, and most of the insurance follow Medicare, these are the criteria. You need to document at least one of these things in order for your patient to qualify for diabetic shoes. So history of partial or complete amputation, a history of previous foot ulceration, history of pre-ulcerative callus. And then number 4 is the one that tends to get people. Peripheral neuropathy with evidence of callus formation. So if you just document that they have an abnormal monofilament, but you don't document that they have any callus, that will not meet criteria. And they really, they want to see not just that you're marking that on the form, but they actually want to see that that matches with your exam. So they're going to ask both for the certification form, and they're going to ask for your last office note to make sure the certification form matches up with what you actually put on your exam. So make sure that, if you are using neuropathy as your criteria for qualifying for diabetic shoes, that you're documenting both. And then foot deformity. I think that foot deformity gets like sort of under documented. So anyone who has hallux valgus, so their big toes are kind of they're producing a bunion. Anyone who has like overlapping toes, anyone who has hammer toes, so again, their toes are kind of like creeping up. All those things are things that would qualify for diabetic shoes, even in the absence of they don't need an abnormal monofilament. They just need to have that foot deformity. And then finally, poor circulation. So anyone, even if you just document cold feet on exam, that will qualify you. So, I get a fair number of patients who are disappointed. They want to see me for diabetic shoes, and then I just document the foot exam, but then they still have to go see O&P to get the shoes actually fitted and stuff like that. So you can save them a trip if you document the foot exam there for them. So kind of just to circle back and to summarize, again, I'm always happy to see anyone you want to send me with diabetes. We're here to help. I really enjoy working with patients with diabetes, but probably the patients that you're going to refer to us the most are going to be patients who have uncontrolled type 2 diabetes, someone who has an unclear diagnosis. You're not sure if they have type 2 diabetes or if there's something else that's going on that's contributing to their sugars. If it's unclear which agents might be safe for them, they're not responding to their treatment plan, anyone on an insulin pump, and then also anyone who's like new to insulin or they just need regular titrations or CGM review. Those are all great patients for us to see. And that's all I had. I can't resist a meme with a Taylor Swift reference, so I just had to include that at the end. But any questions, I'm happy to take them.
Thanks for trying, Gar, and loved the memes in your presentation. They were great. There's a couple of questions in the chat. Just want you to expand on what you mean by atypical diabetes on only diagnosis of type 2 diabetes for patients over 25. If you want to start with those, and then there's another one I'll go to.
Yeah, so in terms of atypical diabetes, that could be someone that you don't know the classification of the diabetes. That could be someone who has like typical type 2 features, but is ketosis prone. I will say the people, so there's certain physicians in endocrine at Michigan Medicine who see atypical diabetes. That group is largely led by Elif Oral. She's a specialist in lipodystrophies. So she sees a lot of like rare diabetes and she does a lot of work with like I said, like lipodystrophy patients, people who have sort of atypical reasons for having diabetes. But since we don't always know, like it isn't my expectation that you would necessarily know who falls in that category. Some people who are referred for atypical diabetes are going to have just like run-of-the-mill type 2 diabetes. So anyone who's diagnosed, following those features, anyone who was diagnosed young, anyone who maybe has a strong family history where you're suspecting they could be MODY or some kind of like genetic form of diabetes would be good there. Anyone who has like classic type 2 diabetes features was diagnosed young. All those things might put them into the atypical diabetes category. So that's sort of a grab bag term, but that's a designation we use on our end for scheduling these patients with someone in a Leafs group, who can do some of the more unusual forms of diabetes and can do genetic testing and things like that. In terms of So it says, please expound on only diagnosing type 2 diabetes for age 25. That's just more commonly. So when you're talking about like diabetes across the spectrum, right? The majority of patients who are diagnosed with diabetes under age 25 are much more likely to be type 1 versus type 2. With people who are diagnosed later on, you're going to see that type 2 predominance. But I did not mean to imply that like only people over age 25 can have type 2 diabetes. Now, we can see type 2 diabetes younger than that. Again, puberty tends to be the cutoff. It'd be exceedingly rare to see someone with type 2 diabetes before puberty. There's some important changes, hormonal changes during puberty that are going to make people more prone to insulin resistance. But yes, you can still see type 2 diabetes in teenagers and young adults. That group is something can be particularly challenging. I mean, people who develop type 2 diabetes in their teenage years, that's a difficult group to treat, I will say. And I find a lot of those patients are actually already followed by pediatric endocrine and then get referred into us. But yeah, I did not mean to imply there that everyone over 25 is some sort of hard cutoff. That's just where your predominance, most people under 25 who are diagnosed are probably going to fall into type 1, and most people over 25 are probably going to be type 2. And then it says, if someone has insulin initiated insulin, you mentioned checking insulin antibodies was not a good option. Would such a patient have manifesting signs, symptoms, phenotype to insulin due to reacting to it and developing antibodies? Not necessarily. When you read, if someone's already been started on insulin, right, you can still check the other antibodies, and GAD65 is going to be your go-to antibody, right? It's by far and away, I use GAD most commonly. And then you can use any of the other antibodies, like I said, like zinc, ICA, IA2. We just don't check the insulin antibodies because you can get false positives, and I wouldn't want to call someone type 1 based strictly on an insulin antibody if everything else was not in that direction. There is in the literature, there is this phenomenon, right, of people who have hypoglycemia, right? Could they have antibodies against insulin? And the fear, right, is that those antibodies react and cause bind with the insulin. And then all of a sudden, once that cluster gets broken up, then all of a sudden they're going to get a sudden insulin release and get hypoglycemia. So yes, there are concerns that people who have insulin antibodies or develop insulin antibodies could have hypoglycemia, and that's always in the differential diagnosis of hypoglycemia. But in terms of are those patients will they not respond to insulin or things like that? No, the insulin antibodies that we see in people who are insulin treated, they're not of clinical significance. We don't normally check those. But yes, in that differential diagnosis of hypo, you'll see that there, but I'm going to tell you it's rare. I've never encountered it in practice where I've had someone who had insulin antibodies that actually became of clinical significance. So I would say you're better off just not checking it. Check one of the other antibodies because it's going to just throw you for a loop if you see positive insulin antibodies.
Now we just have 2 minutes left. Are there any other questions? And they could be questions either for Dr. Iyengar or Dr. Hung, who is still on the call. Well, thank you both so much for presenting. We really appreciate it. It's been really great to hear these different case studies and presentations and information on when to refer. We will have these slides posted and share the recording as well for the attendees in your practice who weren't able to attend, and we'll get out the information about CE credits as well. Thanks again, and have a great afternoon, everyone.